Hello, and welcome to our first NeuroTalk from the Cognitive Division of Global Neurosciences Institute. I'm Dr. Peter Gliebus, and I'm Director of the Cognitive Division within the Institute. Today, I'm joined by my two colleagues, Dr. Catherine Lester and Dr. Jennifer Gallo, and we will be discussing a topic that, as simple as it might sound, frequently brings a lot of confusion. We will be talking about cognitive changes associated with normal aging, about mild cognitive impairment, or the newer term would be minor neurocognitive disorder, and about dementia, or the newer term for dementia would be major neurocognitive disorder. So without further delay, I would like to ask Dr. Lester, so what is cognition?
Well, cognition, by definition, if you were to look it up, is the mental process of knowing or acquiring knowledge and understanding through thought, experience, and the senses. When we as practitioners talk about cognition, we're typically referring more generally to thinking skills, but also to any number of more discrete domains of cognition, including intellectual functioning, attention, processing speed, language skills, visuospatial skills, learning and memory, sensory motor functions, and executive functions.
All right. Now, looking at it with the aging process, is it normal to experience changes in the cognition as we get older?
Yes, to some degree. Just like how any other system of the body begins to slow down a bit as we age, the brain and central nervous system also demonstrate changes that are perfectly normal and expected and not necessarily representative of pathology. This biological and physiological aging occurs gradually, generally over decades, beginning as early as when an individual is in their 30s. As such, everyone experiences slight cognitive decline during the aging process.
Can you give me some examples? What would people experience with that? And do they have any symptoms? How would they present to us?
Sure. So in most cases, normal cognitive aging is characterized by slowing. So people often feel slower to think and slower to do. They might hesitate more or need more time to recall information. There's increased delay in word finding and more of that kind of tip of the tongue phenomenon. Someone might know a person but struggle to find their name right in the moment. There's increased rate of forgetting intended actions, like for what you might have walked into a room. You might misplace things more frequently and feel somewhat more distracted.
Okay. I guess the main question is, when do we consider ourselves as we are aging, and what is that age when we expect, these changes to start occurring?
Well, I mean, the changes do begin pretty early on in life and kind of happen slowly and gradually over time, but they can begin as early as in somebody's 30s. And the reason for these changes, so there's lots of underlying biological changes in the brain that account for normal behavioral decline. You can see brain weight drop as neurons shrink and become fewer. The fluid-filled ventricles widen as the brain tissue atrophies, and there's less blood flow and fewer synapses sending messages through the brain. Remember, though, that when changes occur that are beyond what might be explained by normal age-expected cognitive loss, or when a person begins to have difficulty managing their daily routine because of these cognitive changes, it's important to consider that something pathological may be happening. A comprehensive assessment and evaluation of cognition can help to understand whether an individual's experience is or is not within expected limits for age. Alternatively, a diagnosis such as mild cognitive impairment or dementia might be appropriate. And that is a good segue into turning things over to my colleague, Dr. Gallo, who's going to tell us a little bit more about mild cognitive impairment. So, Dr. Gallo, can you start by telling us, what is MCI?
Yeah, mild cognitive impairment, or sometimes referred to as abbreviation as MCI, or alternatively the term mild neurocognitive disorder, is essentially a clinical diagnosis that marks a sort of middle ground between the cognitive changes expected with normal aging, such as those that you just described, and those concerning for a problem like a progressive neurological illness or dementia. So the cognitive changes that you experience with MCI might include things like more easily forgetting new information or familiar routes, increased confusion, or having a harder time finding words, processing information, or focusing on tasks and conversations as well as before. By definition, the symptoms of MCI are very mild and they don't significantly interfere with your ability to perform typical activities at home or at work, but they're usually noticeable to you or to others that know you well, like family, friends, maybe even your primary care doctor. And the changes may make it harder for you to perform typical activities as easily and effortlessly as you used to.
Okay, and how is it diagnosed?
So when you or someone that you know well suspects that there's been some sort of change in your cognition, you're usually going to be referred for an evaluation by a neurologist and neuropsychologist. Their evaluations include tests that rule out alternate causes for your symptoms and that can detect very mild impairment in cognition. When there is mild impairment in only one aspect of your cognition, so such as maybe only in learning and memory or only in attention or processing speed, the diagnosis is going to be referred to as single domain MCI. When there's mild impairment in more than one aspect of your cognition, maybe such as in memory and attention or processing speed, the diagnosis at that point is usually referred to as multi-domain MCI. So there are different types of MCI that can be diagnosed from the tests that your doctor performs, and these different types of MCI inform treatment recommendations and any follow-up care.
Okay, so tell us about prognosis. Does being diagnosed with MCI mean that someone will eventually be diagnosed with dementia?
It's a really good question. I think it's a question that a lot of people are oftentimes concerned about. It's important to know that MCI may or may not progress and develop into a dementia. The chance of developing dementia 1 year after receiving a diagnosis of MCI actually varies quite a bit. It ranges anywhere from 1% to 20% by some estimates. And about 20% to 25% of people diagnosed with MCI either have no further decline in their cognition or their cognition has improved enough to no longer meet criteria for MCI when they are tested again 2 to 3 years later. And this seems to be because sometimes acute psychological or medical factors like depression or sleep apnea and not a progressive neurological illness like dementia is what caused the initial changes in cognition. And treating those acute factors benefits your cognition overall. So this really means that you can think of a diagnosis of MCI more like a risk factor for dementia rather than as a very early stage of dementia.
Okay, and finally, Dr. Gallo, is MCI treatable?
So in addition to treating any of the acute factors like those just noted, there may be medicines available to treat any specific cognitive symptoms like memory impairment that were identified by the tests your doctor performed. You can also maximize cognitive health and reduce the risk of developing MCI as much as possible by doing things like following a heart-healthy diet, taking all of your medicines as prescribed, getting routine exercise and adequate sleep, and staying cognitively and socially active. Routine neurological care and repeat neuropsychological assessment when you have a diagnosis of MCI is also suggested because monitoring you closely over time really provides optimal care by tracking the need for any additional treatments as soon as they might emerge. And that's going to further inform your risk for developing something like a dementia. And so now that we're sort of embarking on the topic of dementia, I'm going to turn the conversation back over to Dr. Gliebus. And Dr. Gliebus, I'm going to ask you, what is dementia, or sometimes called major neurocognitive disorder, and how is that different from MCI?
Yeah, that is an excellent question. But actually, before I'm going to answer that question, I have a question for both of you, and you're just welcome to answer. So if I'm a person, who is experiencing some forgetfulness, okay, here and there, just from the clinical symptoms, but I function through my life, I work and all of that thing. Just from my symptoms, can we sometimes differentiate whether it's a normal aging-related forgetfulness or it's MCI? Or what is that red flag that would bring me to you guys? It's like, okay, I need, to be evaluated. What would be, what should the people look for?
For me, I think it tends to be when the degree of forgetfulness seems in excess of the person for their age group. They might be forgetting names a little bit more frequently or a little bit more significantly than their spouse or than their friends. Or the difficulties in memory are actually starting to require them to implement external aids to help them remember and keep performing their work duties or activities at home as well as they used to. Dr. Lester, I don't know if you have any additional things to look for.
Well, one other thing that's important to consider is the relative change. If not everybody functions at the same level as everybody else in their age group, so it's not always effective to compare oneself to somebody else. But comparing oneself to oneself can oftentimes better elucidate if a problem is coming on. So, if you're seeing changes in yourself that are raising a degree of concern, maybe some of your closest relatives are starting to say, you're starting to forget some of these things that we talked about, and might trigger a need for further evaluation. And then in terms of, from a neuropsychologist, what we look for, we really kind of crunch numbers a little bit, and there's a degree of, a range of what might be considered normal by age. And once we get into this sort of borderline zone around that normal area is when those concerns for, mild cognitive impairment start to arise.
So am I getting the right impression that really sometimes it is difficult to tell without a further evaluation?
Right. The objective testing that neuropsychologists specifically use in their evaluation can be really, really helpful because it anchors the subjective complaints to some sort of objective marker of impairment on statistical grounds. So it can simply add to the clinical picture rather than just relying on worry or concern about change in function. We actually have the ability to measure it relatively objectively to arrive at conclusions that have some sort of psychometric support.
As much as we want to be, we're not always the best judges of ourselves.
Yep, yeah, and especially when it comes to cognition. So the question for me was about dementia. What is dementia? And again, for the listeners, the newer term for dementia would be the major neurocognitive disorder. But it's just dementia is so ingrained and we're using it so frequently that I will be using this term as we speak. So dementia is it could be a further, like an extension of what Dr. Gallo was explaining about mild cognitive impairment. So if we're talking about the progressive disorder, so as disease progresses, the cognitive deficit continues to accumulate. And we do reach the point, so while mild cognitive impairment, people are still independent or relatively independent. They're driving, they're paying their finances, they're working, and many other things are preserved. In dementia, people already have enough cognitive impairment that it actually starts affecting their independent living. Now, I want everybody to think about independent living. It's a spectrum. So it's not necessarily that you're fully dependent on other people, but you might need help with managing finances. You might start getting lost and you might need, help with driving longer distances or whatever. So that is already, when there is enough cognitive deficit, and it usually then affects more than one cognitive domain. It could be memory and language and attention. And that starts affecting people's independence, and we call that as a dementia.
You mentioned independence, and sometimes individuals use terms such as activities of daily living. The impact on independence, is that the same as activities of daily living? And can you say a little bit more about that?
Yeah, so so activities of daily living are the activities that we perform, just to function through the day. And there are some basic activities like feeding, toileting, etc. And there are some more instrumental activities of daily living that would include, shopping or cooking or managing finances, taking medications. As you can imagine that as the cognitive deficit accumulates or progresses further, the more complex activities of daily living are being affected initially. And that's what we call the instrumental activities of daily living. And obviously when the disease progresses, if we're dealing with a progressive condition, when the disease progresses, then later on, the basic activities of daily living are getting affected as well.
Are there different types of dementia? And is the term dementia the same as Alzheimer's disease?
And that is an excellent question because frequently people are confused. What is the difference between dementia and Alzheimer's disease? Is it the same thing? And I want to look at dementia as a more syndrome. It just tells that there is a cognitive impairment or cognitive impairments for whatever reason, and I'm going to go into this a little bit deeper, but for whatever reason that affects ability to live completely independently. Okay, so this is sort of medical social diagnosis. But if you look under the microscope into the brains of the people who are affected with dementia, there is no such a disease as dementia. Okay, so there are the diseases that bring people to the to give them enough cognitive impairment to affect their independent living when they reach the dementia stage. But the specific diseases that cause this would be, the most frequent would be Alzheimer's disease, but it could be dementia of Lewy bodies, frontotemporal dementia, vascular dementia. So again, dementia is just this umbrella term. It tells that there is cognitive impairment for whatever reason that affects people's ability to live independently. And, but under this umbrella, there are many ways to get into this dementia, okay? And as I said, so Alzheimer's disease is a specific disease. Dementia is just like a syndrome. Think about, because it is confusing. I definitely understand where the confusion is coming from. Think about it as a dementia as a chest pain, okay? The most frequent cause of chest pain is heart attack, okay? But chest pain can be caused also because of the lung problems, because of the esophageal problems, et cetera, et cetera. So chest pain is like this umbrella diagnosis. So dementia is just this umbrella diagnosis. Thank you very much for joining us for our first NeuroTalk coming from the Cognitive Division from the Global Neuroscience Institute. We hope that we explained some of the confusion around around these terms, and we also hope that you will be joining us for the next ones to come. Thank you.